Okay, we'll go ahead and get started. Good afternoon, everyone. Thank you all so much for spending a little bit of time on your busy day to attend our developmental screening summer webinar series. Today, we're going to be sharing a little bit of time with our mental health consultant here at the Bureau of Family Health. She is going to be sharing with us some wonderful information about perinatal depression screenings and supporting your patients. My name is Dr. Teresa Northington, and I am the developmental screening coordinator here at the Bureau of Family Health. And we are so excited to bring this series to you guys. And hopefully something that you hear in one of our sessions will be helpful for you and your patients. So without further ado, I'd like to give it over to you.
Awesome. Thank you, Dr. Northington. Hi, everybody. Good afternoon. My name is Lena Reguette, and I'm a social worker and also a mental health consultant with the provider-to-provider consultation line through the Bureau of Family Health. We are a no-cost mental health consultation line available to pediatric and perinatal providers across the state of Louisiana. And so we provide guidance about screening, about resources, and any diagnostic or medication questions that you may have in regards to the patients that you see or treat. So today I'll be chatting with you guys and talking about perinatal depression, screening and supporting your patients. And I just wanted to say that most of the slides presented today are of the hard work of one of our consulting perinatal psychiatrists, Dr. Juliana Finelli with Lane. So I just wanted to recognize her and give her credit for her knowledge and expertise today. Next slide, please. So some of the learning objectives today, we hope to increase understanding of perinatal mental health issues, increase understanding and importance of screening during the perinatal and postpartum period, increase knowledge of recommended screening tools, and increase awareness of state and national resources for birthing persons and pediatric and perinatal providers. Next slide, please. I wanted to speak a little bit about inclusive language. Not all birthing people identify as women or mothers, and language has power. And this is something that PPCL is working towards identifying and incorporating inclusive language. Some data or studies cited are specific to people assigned female sex at birth and presumed to be cisgender. There is data that's lacking for transgender and gender diverse birthing and parenting people. Next slide, please. I first wanted to touch on gaps in care. Mental health problems are the most common complication of pregnancy, and they're actually more common than the physical health problems. And I'm going to get to that data that demonstrates that mental health problems are indeed a pregnancy complication in just a few slides. But yet less than half of women with perinatal mental health problems are identified. Even when they are identified, they tend to not receive treatment. Research has shown that 75% of patients with perinatal mental health symptoms go untreated. And if they do manage to get referred to psychiatry, we've seen that training and research gaps mean that they tend to be undertreated. Next slide, please. And I wanted to touch a little bit more about the training gap because I think it surprises a lot of folks outside of psychiatry to know that most psychiatric residency training programs do not include significant training in perinatal psychiatry. And this is despite the fact that 50% of psychiatry patients are women, and 80% of them will experience at least one pregnancy, and 50% of all pregnancies are unplanned. The good news is that fellowship training in reproductive psychiatry has grown, but they don't require psychiatry residents to demonstrate competency in perinatal psychiatry before they graduate. And if we look at our colleagues in OBGYN, they too have minimal training in perinatal mental health. There are around, I think now, about 16 perinatal psychiatry training programs, which is a significant jump from only 5 less than a decade ago. Next slide, please. So what can pediatric and perinatal clinicians do? So there's a few things. We recommend early identification using universal screening, brief intervention, refer to mental health treatment, and in cases where the caregiver is the patient, implement some first-line intervention. Next slide, please. So screening criteria. In medicine, we screen for disorders that are prevalent, that are identifiable with low-cost measures that cause impairment and are treatable. And the next few slides will break that down a little bit further. Next slide, please. Screening for perinatal depression. As we said, we screen for disorders that are prevalent. It is shown that up to 1 in 5 women are affected by perinatal depression. But the good news is that we can identify and screen perinatal depression with low-cost measures. There are free self-reported measures that are available. Most of them are less than 10 items, so it takes under 5 minutes to complete, and scoring of these screens take less than 4 minutes. Next slide, please. So they cause impairment. So maternal suicide is a leading cause of pregnancy-associated death. Infant offspring of mothers with prenatal depression have been found to demonstrate frontal EEG asymmetry patterns, which are a reliable index of individual differences in affect regulation. So, perinatal depression and anxiety can cause impairment not only for the birthing person, but can have some negative infant outcomes as well. Next slide, please. And we think that at least some component of this association is mediated by parenting difficulties. Just to list some, depressed mothers are more likely to report feeling less competent, or more likely to be observed as having more irritable or disengaged interactions with their infant, and fewer interactions overall. And we know that those early interactions with caregivers are so critical in developing those building blocks for emotional regulation. Next slide, please. So I'd be remiss if we didn't mention fathers and the prevalence of paternal postpartum depression. Research has shown that the prevalence is about up to 1 in 10 fathers, and this increases to 50% when mom is also experiencing perinatal depression. Research has shown that it is associated with reduced parenting engagement, so that limited interaction with the infant, decreased warmth and sensitivity. We've noticed an increase in couple conflict, so a higher incidence of inter-partner violence, an increased risk of depression in the partner. And by the end of the first year, fathers with PPD are more likely than fathers without depression to report spanking their children. Next slide, please. It's treatable. So evidence indicates efficacy of screening, utilizing supportive approaches, psychotherapy, and the use of antidepressants. Next slide. So, big question, when to screen? The American College of Obstetrics and Gynecology, also known as ACOG, has recently released some new guidance. They are promoting screening at the initial visit, later in the pregnancy, and at postpartum visits for depression and anxiety using a standardized validated tool. They also encourage and support a full assessment of mood and emotional well-being, including that screening for depression and anxiety during a comprehensive postpartum visit. However, the challenge is that many women do not keep their comprehensive postpartum visits, and perinatal depression is associated with missed appointments. And so by the pie chart here, we see that depression could present earlier or later in pregnancy. But most often we see that about 40% of women develop symptoms after childbirth. And I wanted to touch on if a patient answers a self-harm or suicide question within a screening tool, then ACOG recommends that the clinician or provider should immediately assess for the likelihood, the acuity, and the severity of risk of suicide, and then arrange for a risk-tailored management approach. Next slide, please. So AAP Recommendations, that's our American Academy of Pediatrics. Their recommendations is to screen for maternal depression at the 1, 2, 4, and 6 month well baby visit. Psychosocial assessment at every visit with some specialized attention to poverty and behavioral health. And the pediatrician's role is that of screening and referring when necessary. And when the pregnant or postpartum person is the patient, that may include implementing some first-line treatment. Next slide, please. So which screening tools? Some of the recommended screening tools that we support and recommend are those that are validated in the perinatal period. They are free, they're easy to administer, easy to score, and available in multiple languages. And those for depression are the EPDS, better known as the Edinburgh Postnatal Depression Scale. And this is a 10-item scale, also screens for anxiety. Another supported screener that's recommended is the PHQ-9, but this screen only looks for or identifies depressive symptoms, so that doesn't have those anxiety questions like the EPDS does. A recommended screen for anxiety would be the GAD-7. Bipolar disorder screen would be the MDQ, which is the mood disorder questionnaire. And screening for PTSD, the primary care PTSD screen, or the PTSD checklist civilian scale. And again, all of these are available in multiple languages. They're free. And I'll share with you some resources on how to access these screeners easily towards the end of the presentation today. Next slide, please. All right, so screens that are specific to the pediatric setting, ones that recommended, again, because it's free, and this one includes the PHQ-2 items, is the SEEK. It's the Safe Environment for Every Kid. And it asks questions about environment and social determinants of health. And so the other screen that's recommended would be the Survey of Well-Being of Young Children, also known as the SWIC. And it contains the EPDS items for the 1, 2, 4, and 6 month age specific recommended screening times by the AAP. And so on the next slide, it just shows us the SEEK, and it pulls out the questions from the PHQ. Just wanted to let you guys have a look at that. And if we go on to the next slide, we'll see the SWIC, where it also pulls out those questions about mood and mental health. Okay, next slide. Who does the screening? Support staff can provide the screening tools at check-in or upon rooming. I know some pediatric clinics, they may have a online screening tool process. So sometimes screens can be done prior to the visit. Support staff can then score the screen and can enter the result into the EHR, the medical chart. And then it's recommended that the responsible licensed clinician should be aware of the score and should be the one providing the feedback and determining next steps with the patient. And this includes the response for the question about suicidal ideation. And it is recommended that screens must be scored before the patient leaves the appointment because of the suicidal risk questions. Next slide, please. So how can we introduce screening? These are just, a few examples of how we can introduce screening when meeting with new parents. We could kind of just edge into it saying that we ask all patients these questions because mood changes during pregnancy or after giving birth are very common and they can affect your health and your baby's health. Or just letting the patient know that answering these questions can help us, kind of guide and figure out how to help you best, excuse me. And these are all adapted from Lifeline for Moms, which is a great resource if you're wanting to learn more or get some clinical tools about mental health to utilize in your practice. Next slide, please. Understanding screen results. Screens are just one element of the clinical assessment. They are not diagnostic, so they should not, stand alone in determining a diagnosis or a treatment plan. A negative screen shows us a low likelihood, but valid screens can have up to a 20% false negative rate. So if the screen doesn't match the presentation, it's important to pay attention to our clinical judgment. And then a positive screen usually reflects higher than usual probability and oftentimes will warrant a specific plan. Next slide. All right, addressing a negative screen. These are just some things you could use within your practice to address a negative screen with a patient. Thank you for filling out this screening questionnaire. We ask everyone these questions because depression and anxiety are so prevalent or common during pregnancy, and it's so important that we be able to offer help. This is a good opportunity to highlight behaviors and strategies to maintaining wellness and to offer or identify some resources that may be helpful. Next slide, please. Addressing a positive screen. Another example, so you can say, thank you for filling out this screen. It sounds like you've been experiencing low mood and stress and that you may be depressed. Depression and anxiety during pregnancy are common. You and your baby deserve for you to be well. There may be many effective support options available. It'd be okay if we discuss those. So creating a safe, open environment for the patient to discuss the screen and maybe discuss next steps. And again, identifying those support systems and resources that can be and would be helpful to the patient. All right, next slide. So other screening considerations, I know I mentioned the MDQ earlier. So just if we have any prescribers that are tuning in today, before initiating any antidepressant treatment, it's important to administer a mood questionnaire of some sort. The mood disorder questionnaire, again, is one of those free, comes in multiple languages, easy to score. But I just want to highlight that postpartum period can carry the highest lifetime risk for bipolar disorder, and antidepressants can increase this risk for mania, psychosis, hospitalization for patients with bipolar disorder. And what we've seen in research is that 23% of positive scores on the EPDS is bipolar depression. So just wanted to include that in considering and thinking about screening. Next slide. So when caregivers have a primary care provider, these are just some examples of things that you can say or talk about with the patient. If you're not the PCP, it could be wise to consider calling the PCP to coordinate care in the event that there's a positive screen and if the patient gives consent. And we also recommend the use of a screening passport. It's pretty neat where the patient can bring the screening passport to their providers if they have more than one. It helps to keep kind of a log and a history of screenings that were done, so where you can kind of see either like over time improvement or decompensation with mood and other symptomology. And next slide. This highlights a screening passport that was developed through LAMP, which is now PPCL. But the LAMP website is still active. It will be transitioning to our PPCL website in the next few weeks. But I just wanted to include it on the presentation today so you can get an idea. And at the end of the presentation, I'll also have links for you guys to be able to access a lot of these clinical tools. Next slide. And in thinking about infant and early childhood mental health and parenting interventions, in the state of Louisiana, we have a few programs. One is the Nurse Family Partnership Program, and another is Parents as Teachers. And so if you identify patients who could benefit from either NFP or PAT, this is an option for referral and extra support for mom and baby. Another options are infant mental health specialists. These specialists are usually have specialty training in evidence-based practices. Couple off the top, maybe certified in PCIT, which is parent-child interaction therapy, CPP, which is child-parent psychotherapy. And so those two interventions focus specifically on the parent-child dyad. And lastly, perinatal mental health specialists. These folks have specialized training in perinatal mental health and have gone through many classes and hours and specialty training to specifically address perinatal mental health in the perinatal and postpartum period. Next slide, please. And this is just kind of a snapshot of what the LAMP website looks like and how to access those clinical handouts that I mentioned earlier. And again, this content will be transitioning over to the PPCL website in the next coming days or weeks. But clinicians will have access to these clinical tools, which include care guides, clinical handouts, all the screening tools that I mentioned today, and past webinars and presentations and other resources that could be helpful within practice. Next slide. And here are some of our resources that we recommend. Again, lamp.org, lamhpp.org, and our PPCL website. I'm going to, as I'm wrapping up, I'll go ahead and I'll copy and paste these into the chat so everyone could have access to that. But we'll go on to the next slide. And I'll open up the floor to any questions. And this is our contact information. We are the provider-to-provider consultation line. This is how you can contact us. And on the next slide, if anyone is interested in accessing our website, you could scan the QR code. Or if you're interested in registering for PPCL, again, it's a no-cost consultation program. You can access us Monday through Friday, 8 to 4:30. The consultation line is staffed with licensed mental health professionals, and so I'm one of the folks that screens and accepts calls on the consultation line. And we also have a team of child and adolescent psychiatrists and perinatal psychiatrists that can answer any questions about diagnoses or medication management or guidance with your patients. And it's open to any clinician that provides support to either children or pregnant and postpartum women. And I'll go ahead and I'll drop those resources in the chat.
Okay, let's see if we have any questions. Thank you so much for putting all of those great resources in the chat. And once again, if you came in a little bit later, if you could please put your information into the chat, your name and where you are working around the state, and your title would be wonderful to have in our chat. Elena did just put all those great links in there, and we'll also try to send those links out too as well. We won't, there's a question there about getting the slides. We won't actually be sending out the slides to everybody this time, but we have recorded this webinar and it will be available on our YouTube channel, as well as the Developmental Screening Toolkit webpage. So you'll be able to access this information and kind of do a little refresher or review whenever you can. We would love to thank Elena so much for providing us with this amazing information and wonderful resources. At the conclusion of this webinar, if you are seeking CE or CME credit, please make sure to fill out the evaluation and we'll get those certificates to each and every one of you. Thank you all so much for attending today's Developmental Screening Summer Series webinar, and we hope that you have a wonderful day. Thank you. Lena, if you're still on, could you repost those links in there? I think you only sent them to the host and panelist, but if you could send them again and just select everyone at the bottom, that would be wonderful.
Absolutely. Sorry about that.
No worries. Thank you. There we go.